So, good morning, everybody. Can I just check that people can hear and see me? Just a couple of thank you very much for the head nodding. That's really helpful. Thank you. So I'm Dianne Mardell. I'm the Managing Director at the North West Leadership Academy, and it's my great pleasure to welcome you to the masterclass today, leveraging opportunities within integrated care systems. We've got a great panel lineup, as you'll have seen, with representation from each of our three systems. So I'm sure we're all looking forward to hearing what they have to say and then to participating in the call. You should have had sight of a housekeeping slide, I think, at the beginning, so if I can just ask you please to take note of that. Slight reminder, if you could keep microphones off during presentations, just so we can all get the best experience. We do want this to be as interactive as possible. Please use the chat box. It will be monitored, it will be managed, and that's a great way to be communicating as we go through the session this morning. Also, just a reminder, you should have had a message come up to remind you that we are recording the event. So just so that you're mindful of that, and then afterwards, of course, that does make it available for a wider audience, which is a great thing to be able to do. Also wanted just to say a little bit about the collaborative, what brings us here today. We have worked together as a collaborative in the Northwest for a number of years now, as many of you will probably know, and the 5 partners come together bringing their own specialisms, their expertise, and it's a great way for us to be able to bring to you collectively some really good expert speakers, some things that can really help you to think a little bit differently sometimes about the work that we're doing and the impact it can have, and to hear some fresh views and to get some fresh thinking. So the 5 partners are Aqua, MIAA, ourselves at the Academy, ADAS and Northwest Employers. So I would say long may that continue. It's proved to be very successful, and we're certainly greater than the sum of our parts when we come together in that way. So unless anybody on the team gives me a nudge and tells me I've missed anything, I'm going to hand over now to our co-chairs today. So we have Helen and Helen, so I shall let them introduce themselves and look forward to seeing you again shortly. Thank you.
Morning. Thank you, Dianne. Hello, everyone. I'm Helen Wolstenholme. I'm Assistant Director for Partnerships and Support at the ICS Network at the Confed, and I'm here with my lovely colleague and co-chair, Helen.
Morning, everybody. I'm Helen Hunter. I'm an Assistant Director in the ICS Network as well, working on place development. Up until about 6 weeks ago, I was an Assistant Director working in the Northwest. So it's very nice to be back amongst Northwest colleagues and learning more about what these systems are working on at the moment. So great to be here.
Thank you. And just in case anyone's not familiar with the ICS network, we're here to enable leaders to exchange ideas and share experiences and challenges and influence the national agenda. And we're really thrilled that all 42 ICSs are members of the ICS network. And you may have seen that in the summer we published our State of the ICS report, which is a bit of a stock take as to where the ICSs are at 1 year on from coming into being. So we'll pop the link to that in the chat so you can have a look at your leisure. You may also know that the ICS network is part of the NHS Confederation. So we also have networks for the acute providers, community providers, primary care, mental health, and we host the Race and Health Observatory. So we're really thrilled to be here today. This exciting Northwest Masterclass is going to consider the developments within this region over the last 12 months. So we'll be hearing from the regional ICB leaders on how these systems are driving forward change and integration in the challenging context that we're in at the moment. And as I mentioned, July 2023 was the first anniversary of the ICSs. And so these partnerships in the Northwest, the masterclasses, have come together to provide a collaborative and reflective space for the leaders to share their experiences and learning as they continue to lead across the systems and to meet those 4 purposes of the ICSs on improving outcomes, tackling inequalities, improving productivity and social and economic development. So you've got a cracking panel here today. You've got Graham Urwin, who's the Chief Exec of the Cheshire and Merseyside ICB, Sir Richard Leese, who's the Chair of the Greater Manchester ICB, and Kevin Lavery from Lancashire and South Cumbria ICB. So what we're going to do is go into a bit of a chaired panel session. So each of you speakers are going to give a presentation and there'll be a couple of questions, and then we'll go into a panel conversation where there's some more questions. So please do think about what you'd like to ask the panel today and submit your questions in the chat, and then we might have a chance to come to people later on this morning. So first of all, I'm going to go over to Graham. Good morning, Graham.
Good morning. When you said that people should keep themselves on mute for the benefit of all, I wondered if maybe that included me for this presentation. That would help. So, rightly or wrongly, going first amongst the three of us, I'm going to talk a little bit more about the context, because certainly looking at the attendance list and the people who've joined us this morning, a lot of people who work in a provider setting, a lot of people who work in not ICBs, for want of a better word. So we'll try and set some context. So the first thing is, if you go back and listen to the work that the NHS Confederation have done, one of the great quotes that they used fairly early on was, "If you've seen one ICB, you've seen one ICB." We are all slightly different, and one of the things about the Northwest is we are exceptional in the fact that we are quite large. So Cheshire and Merseyside, we're serving a population of 2.7 million people. There are 17 NHS trusts. That's the largest number in any ICB in the country. We work with 9 local authorities. We've got 350 GP practices. We've got 50 primary care networks. And if I went on to list the number of pharmacists, ophthalmologists, you start to get a feel for the size and the scope of this. Now, ICBs were the legal successor body to the former 9 CCGs. But what was really important was we were not trying to create just a strategic commissioner, and nor were we trying to create just a big CCG. This was a chance to do something fundamentally different. This was a chance to drive a new level of collaboration within the NHS, and our 17 NHS trusts in Cheshire and Merseyside arranged themselves into 2 provider collaboratives. And I'm now duty bound to say, for any of you who follow the HSJ, one of our provider collaboratives shall now be known as an award-winning provider collaborative, because they won something at the HSJ Awards last night. But the other side of it is not just collaboration within the NHS, but integration with local government in a way that we haven't been able to achieve in the NHS before. Now, carrying on with this point about context, the best way to describe the ICB is through these 4 purposes. We are there to improve health outcomes and healthcare. We are there to ensure value for money and productivity. We are there to tackle health inequalities. And we're there to contribute to the socio and economic impact within the communities that we serve. Now, at any point in time, the balance that we will spend between those 4 things will differ. Yeah. What I would want to say to people is, I joined the NHS in 1989, and this is the hardest period that I have ever worked through. That's the context being consequences of 10 years of austerity, the after effects of COVID, the work that we've had to do to deal with industrial action, and a social care system that's been more affected by austerity than the NHS has. And so, quite unashamedly, we're also in a position where we are spending more of our time focused on delivering today rather than spending our time getting upstream. And it's really important that ICBs, if they're going to mean anything, are able to spend more of their time getting upstream. Now, I couldn't be in any audience at the moment without just saying a heartfelt thank you to everybody who has dealt with the consequences of industrial action, who has helped keep services safe, and the extraordinary levels and efforts that they've gone to do that. And that's not just frontline staff, that's absolutely everybody who works in the NHS, all the way through to the people who have to spend time on the phones, contacting patients, rebooking their appointments, rescheduling and reorganising things. And the other thing that I need to say to you is, we've got Countess of Chester as one of the NHS trusts within our patch, and we're absolutely rocked to our core by the Lucy Letby case. How any of us, ever contemplated that somebody working for one of our organisations could have done what was done is something that quite rightly rocks us to our core. But actually, the Countess, supporting the Countess, and as a system dealing with the after effect of that, and possibly another 3 years in the court system, an independent inquiry, is something that is an added responsibility and is an added pressure on the time of the leaders in our system. Now, it is an absolute privilege, I think, to do a job where we are paid to do our job by the taxpayers. That creates an accountability for what we do. And therefore, rightly or wrongly, right now our priorities are dictated to us by the government. And priorities being dictated to you by the government, that is a government at the end of their term, will be different to a government that is at the start of a 5-year cycle. So when I say to you we are spending too much of our time right now focused upon delivering today rather than the getting upstream, the work that we're doing as a Marmot community, trying to make intergenerational changes to people's lives to try and tackle the health inequalities that we suffer, because the government are telling us right now they want us to improve short-term access to GPs, including through the telephone systems. They want us to, post-COVID, reduce waiting times for the longest waiting patients. They want us to focus on making sure that we've got good flow through our system, good ambulance response times, good ambulance handover, minimising people's waiting times in A&E. And all of that fits together and only happens if we can actually keep people healthy and avoid admissions in the first place, but we can also expedite discharges. And the other thing is they want us to manage the money better. It's a real tension between the NHS and local government. And frequently my partners in local government say to me, the problem with the NHS is you've got no discipline. You don't balance your books in the way we have to do in local governments. Well, the reality is the NHS does balance its books every year, but it balances its books once nationally, whereas every local authority balances their books at a local level. And that once nationally kind of creates a bit of a smoke and mirrors. Nobody really quite knows how tight the financial envelope is. But the financial envelope for the NHS this year, partly because of the consequences of industrial action, partly because of pay inflation, but partly because of some extreme costs associated with oil prices post the Ukraine war, drug prices post Brexit, the NHS is probably in more danger of failing at a national level to balance the books this year than ever before. So we have an absolute focus at the moment on trying to manage the money better. So just to sum up very quickly for me, I've kind of set some context. I've talked about what the priorities are today, but I just want to pick out a few points of good news. So in Cheshire and Merseyside, we have had the biggest improvement of any ICB in the country around the early detection of cancers at stage 1 and 2. We have only done that because of something called the Lung Health Check programme that we do hand in hand with our local authorities and with our voluntary and community sector partners. An example of the type of things that through integration works better together. We've secured massive additional investments in diagnostics, and this is diagnostics that used to take place in hospitals that now take place in community settings. We wouldn't have identified and mobilised this so quickly without the help of our local authorities and their insight into the spatial planning and the availability of locations and the right locations in their system. And the final thing I just wanted to mention is women's hubs. Some of you will have seen an announcement recently directly by government ministers that they want every part of the country to set up at least one women's health hub. And actually, that was an idea that was born in Liverpool. It was an idea that was born between the sexual health team that was funded by the public health grant in Liverpool City Council and one of our primary care networks, that in a deprived area of the city where historically women were unfortunately having more than one termination in their lifetime, we have seen in each of the last 2 years a 25% increase in the number of women using long-acting reversible contraception. That is making a fundamental difference, and is only happening because we've created the circumstances for people to get on at a local level and to deliver integrated solutions between local government and the NHS. I'm going to pause there and really happy to take questions from one of the Helens and then later from the combined room.
That's brilliant, thank you. And I was struck when you were talking, you mentioned the sort of twin challenges of trying to continue the focus on those 4 purposes, but also dealing with today's short-term pressures. And our Chief Exec, Matthew, calls that split screen thinking, and how you try to do that. But also you referenced the increasing responsibilities of the ICBs at the moment, and that context of reducing funding and finance. And there's the old adage of necessity being the mother of creativity. And I just wondered if you find that to be the case in the ICB, or if that's presenting some real challenges at the moment, if you feel it's kind of spurring everybody on and giving people the ambition to find ways through this really difficult time, or if it's proving really difficult.
So one of the things that I didn't say to you is, as well as the board of the ICB, which I suppose I think is the thing that is kind of running, holding to account and performance managing the NHS, every ICB also has something which is called an integrated care partnership. And the integrated care partnership is a legal partnership between, in our case, the one ICB and the 9 local authorities. It's chaired by a local authority leader, and that comes together and effectively is a space in which we can really concentrate our minds and do some forward planning. It also, from my point of view, almost refreshes my mind and gives me some hope about the things that we are doing for the future. So just this week, we had an ICB session focused solely on children. And I kind of love the quote that somebody gave me that said, well, children are 30% of the population, but they don't get 30% of our time. And that gives rise to that lie, doesn't it? That says we like to call ourselves the National Health Service, but really, through successive governments, we've become the National Illness Service. And it's to put the H back in and get us back into that place. So that's one of the things the ICP does for us. And then if I turn the clock back to its previous meeting, kind of 2 months ago, one of the things that we did there was we had a whole session on health and housing. Now, we've done some groundbreaking work using data and sharing data that has helped identify, and lots of ICBs will be doing this, identifying those patients most at risk of admission to hospital through breathing difficulties, and trying to risk stratify those. But actually, if you then start to take local authority data and housing association data into that space, you start to identify those where a contributory factor is the housing they're living in. And I think 2 things: the programme through Liverpool City Region that has brought in all of the inward investment to replace boilers is really important, but the willingness of our housing associations to want to change the way they prioritise not only people on their waiting list to get people with people who are vulnerable into the right type of housing, but to invest in improving repairs. So it's the stuff like that that refreshes me and gives me hope that through integration and working together, we can make a difference in the health outcomes of the people we serve.
Fantastic, thank you. And yes, absolutely, ICP's tremendously important, I think, for ICSs generally. The state of the ICS report that we published in the summer found exactly that, and some phenomenal examples of progress and partnership working there. And in the last 18 months, could you, from those many really strong examples of progress and success, could you pick one thing, your biggest success of that integrated working in your system?
Well, I'm going to give you two answers to that.
Okay.
So I think the biggest success under the integration is the work that we've done around sexual health. You know, we have in our patch the two local authorities that have the worst female life expectancy at birth statistics in the whole of the country. So to have focused on and to trailblaze on women's health hubs, and to actually have DH ministers pick that up and write to every ICB in the country and say, you need to pilot at least one of these, is something we should be proud of. But that's integration. But in the collaboration space, we were one of the first ICBs to make sure we had nobody waiting more than 2 years. We were one of the first ICBs to make sure we had nobody waiting more than 18 months in the kind of post-COVID cutting of the waiting lists. And that came through the collaboration and how all of our acute trusts came together to manage elective waiting lists, the elective recovery, and deploy mutual aid in a way that we'd never seen before. One hospital giving theatre space and theatre time to another hospital, not just transferring the patient, but giving the opportunity for the surgeons and the theatre team to go and work at a different site. And I think all of the time, those little examples of both integration and collaboration shows that this is the right model for the future. But these things do take time, because the NHS went through 30 years of an attritional and contestable knowledge, contestable system. And you don't unlearn that overnight. You just have to keep nudging people in the right direction.
That's lovely, thank you. And we have got questions coming in the chat, so we're going to come back to those a little bit later when we've spoken to the other panelists. But Graham, thank you very much. That's been really, really interesting. And thank you for sharing your experiences. So now I think we're coming over to Richard. Hello, Richard.
Morning, Helen. Yes.
Morning.
Okay, well, I'm ready to go. I'm going to give a different perspective, I think, to Graham and Kevin that follows me, because they're both chief executives. I'm a non-executive as a chair. And also, a bit like Kevin, but unlike Graham, I don't come from a health background. I come from a local government background. I was a council leader for 25 years, although I can point to working with health for over 20 years and go back to chairing a health action zone back in 2000 for Manchester, Salford and Trafford, which, amongst other things, led to the then 3 primary care trusts in Manchester and the council establishing a joint health unit. And there's a sense of deja vu here, because the joint health unit was established to tackle health inequalities. And 20 years later, we've got statutory partnership with between health and local authorities to do precisely that. I'm going to probably start off fairly negatively, but I'm going to become more positive by the time I finish. And this is partly having come into the health service some 18 months ago, and I think I'm still suffering from culture shock, to be honest, about making that transition. I'll pick out some of the things that I found well, in between surprising and shocking. Graham talked about the way the finance is managed within the NHS, which I think the financial systems and rules I still find completely bizarre. 2 of my NEDs come from financial backgrounds, one in housing and FE, one in local government. They find the rules bizarre as well. And NHS finance almost operates in a way that guarantees inefficiency. So that's one thing. I now have more passwords for different NHS applications than I have for anything else put together. I was warned when I got my first NHS laptop by the person who delivered it to me, is that if I thought IT was bad in local government, I ain't seen nothing yet. The levels of bureaucracy, again, local government is renowned for bureaucracy. Again, it's not a patch on the NHS. I'm not going to go into all the things, but one other is the obsessive lack of openness and transparency. So initially, just getting my committees to meet in public was a battle that had to be fought and won. And I still have to battle about having more people on more things in the public agenda than on the private agenda. So a lot of challenges there. The last 16 months have been challenging. Transition from, we had 10 CCGs that we had to transfer just short of 2,000 people from 13 different organisations into one. We had the 30% cut in running costs in the middle of this, and 16 months on, we are only just now finishing that transition, and that clearly has had an impact on delivery, and it certainly had an impact on morale. It has been for us very disruptive because of the devolution agreement we had prior to ICSs coming in. All 10 of our local authorities had joint commissioning arrangements with their CCGs. A lot of them had joint appointments, joint premises, a whole range of activity that effectively stopped overnight and has had to be rebuilt. And in terms of the acute sector was not part of the devolution agreement for Greater Manchester, so that's new into the system. And what we didn't know is that NHSE were handing us a structural deficit of several hundred million that we now have to resolve. We've clearly, as Graham's talked about, that we had industrial action. We've also had our own, not to perhaps the scale of the Countess of Chester, but we've had our own challenges in particularly difficult problems. Edenfield is probably the most obvious one for us, featuring in the Panorama programme. That was filmed before the ICB was in existence, and it's a nationally commissioned service, but it's still clearly a role of the ICB working with national colleagues to pick the pieces up there. So a lot of very challenging things that we've had to face, and alongside that is, I'd have to say, poor performance on constitutional standards. But the data I see is that that's probably Greater Manchester is the worst, but the Northwest generally is not doing that well in that area. So challenges around that. Having said that, if that's the negative stuff, I'll now turn to the positive stuff, because I do think I'm convinced that the ICSs are the right way forward, and I'm convinced now that we will be able to make a difference. Even though we do have to do what Graham talked about, which is dealing with the here and now and the very real pressures now, as well as being able to get upstream. It was probably only our September board meeting, so after we've been in existence for 14 months, that I first felt that we were beginning to talk about the things that we've been set up to talk about, rather than running to catch up. But we have got to that point, and we are being able to do things about getting upstream. And getting upstream is not a nice to have. If we look at our financial projections and segmentations over the next 5 years, if we were to do nothing, we're looking at the deficit we've currently got increasing by £1.4 billion over that period of time. And most of that increase does not come from demographic aging, it comes from prevalence. So unless we can get upstream and challenge that prevalence, the situation is just going to get worse and worse. So what is working well? Well, I think partly because of the history of devolution is that in all 10 districts in Greater Manchester, there are really good relationships between health and local authorities. So we started off on a strong base. Our Integrated Care Partnership Board was up and running relatively quickly. We have, I think, a very clear and very strong strategy, and we're already in the process of the partnership board holding the partnership to account for the delivery of that strategy. So we are into the operation of that strategy with accountability to go alongside it. We've reviewed our governance arrangements. We've got a new operating model in place. Our locality boards are all up and running. They all have a format of being joint committees with the Integrated Care Board and the local authority, but also Section 75 committees as well. They've all adopted the same format, and they're all now, I think, operating well, although to a certain extent it is business as usual for our localities in that they're still continuing, their local care organisations continuing to develop what they were doing previously. Our primary care board, which includes all 4 disciplines of primary care, has become the Primary Care Collaborative. And as I say, it includes all 4 disciplines. The current chair of the Primary Care Collaborative is a pharmacist, and the one before was an optometrist. So there's real recognition of the other disciplines alongside general practice. We have an alternative provider collaborative. Our voluntary community and social enterprise sector have got together and formed their own collaborative, and that collaborative forms part of our governance structures. And we've begun to develop the right strategies, and having a strategy and delivering it are different things, but all of these strategies have been follow the principles of being asset-based, of co-design, co-production. That takes longer. If it takes longer, that means it's more likely to be delivered because of the process we've gone through. So we are, as a system, reforming primary care through our primary care blueprint. Primary care blueprint, which is very much a social model. Not that clinical isn't important, it's an important element of it, but it is a social model of tackling population health. Similarly, our mental health strategy is a social model. It normalizes mental health. Mental health, like physical health, is something we all have all of the time. Sometimes it's good, sometimes it's bad. Mainly it's on a continuum there, and it also, I think, equalises the relationship between mental health and physical health as well. It's part and parcel of the same thing. I think we've started to make real progress on equalities, including board members starting to take personal commitments for the equalities agenda, and we do have a very clear developing financial framework that allows us to look forward over 5 years, and we are moving to operational planning that will always also allow us to plan over the 3 to 5 year period of time, not what are we just going to do next week, which is, I think, what we inherited. So there is more within that, but I think a lot of positives about how, through working as a system, we're able to see a whole picture and start to take actions as a system in how we tackle those issues across the whole picture, and in particular to do that thing that Graham talked about, is how we start to get upstream and do far more in the preventative and early intervention field. Graham mentioned long checks. I just have to, and I think he claimed an award, which, congratulations to the award winner. Actually, one of our primary care practices in Tameside also won an award last night. But long checks started in a car park, Asda car park in Harper Hay in North Manchester, and I think it's just it's a shame it's taken about 10 years for them to be rolled out, because they really do work. Thank you. I'll finish there.
That's lovely. Thanks, Richard. And an awful lot to cover there. And I just wanted to pick up on a couple of things that you mentioned, if that's okay. And the first one is around primary care, because we've heard from a couple of systems that the primary care members are sometimes feeling that they're struggling to be heard on the board, so they don't feel like they're able to make the inroads that they want to, and that might be about timing, or it might be about their ability to get to the right conversations at the right time. So I just wondered how you'd been able to really make that happen, with the primary care board that you mentioned, and how those structures are set up to make sure that you're really incorporating that primary care voice at the very top level on the ICS.
Okay, let's work down, I suppose, or from the ICB board. Clearly, we have a primary care representative on the ICB board. This is a general practitioner. On our partnership board, we have 4 primary care representatives, one from each of the disciplines. So we've got an optometrist, a pharmacist, a dentist and a GP on the primary care board. The primary care collaborative, as it now is, includes all 4 disciplines, although it has 4 subcommittees covering each of the disciplines, and we require a locality level for a clinical leadership group that would also include all the disciplines of primary care within that. So our governance structures build in a primary care voice at every level within the structures. If you get down to a neighbourhood level, you can almost say that primary care has primacy there, because they are really driving a lot of the work that takes place at a neighbourhood level, working with local neighbourhood, local authority teams. So there is a voice at every level. It's very much built into the structures. In terms of our ways of working, I talked about the primary care blueprint. I think it's one of a number of policies that we've adopted in relationship to primary care. I also talked about that being co-designed, co-produced. So people within primary care were very much part of the authorship of those strategies, which also is why I think they've got more chances of working. And we see that the national pressure around GP access and dental access and so on. I think we need to be clear is that most of our colleagues within primary care don't want to be continuing to operate in the way they have done. They are up for operating in a different way. So our job is to work with them and to be able to support them in being able to do that. And that's what we're doing.
Smashing, thank you. And then I wanted to pick up a point about place as well. And you mentioned earlier that you already had a kind of system-wide locality approach before the ICB came into being. So I just wondered, how did that formalisation of the ICB influence that? Did it kind of create more opportunities that weren't possible before, or did it not really make any difference, or did it hold you back in any way?
Yeah, we had a structure based on, I think, 61 neighbourhoods across Greater Manchester that goes back to probably about 2015. So the sorts of things that you see, for example, in the Fuller report that we've had in place for a long time. If we're honest about it, the establishment of the ICS, it certainly in the first instance knocked a lot of that back. It has put us backwards, but I think working with our colleagues in local authorities, we've now got ourselves into a position that we've recovered the ground, and we can have a far stronger delegation to place through the new locality boards. So having been knocked back, I think we're now in a position to be able to move forward from where we were. I think the biggest difference as well is that now the acute sector has a far greater role in place arrangements. So every locality board has an acute provider, in some cases 2 acute providers sitting on the locality board. I think all of our acute providers are providers of community health services anyway. And in some, probably Rochdale is the best example, where we don't just get integration between primary community care and social care. We've got some genuine integration with the acute sector as well. So we're being able now to, in a real way, move into that space.
Lovely, thank you. And then the final question is the same one I asked Graham. You know, since the ICBs were formalised, what would you say, if you could, your kind of single biggest success from working in this new way?
I think the biggest single success is that that we've been. I don't know if this is a single success or not, but it is that we have clarity of purpose, we have a clarity of strategy, we have a very clear delivery plan, and we have broadened the range of partners and stakeholders that have been part of designing that and are brought into the delivery of it. So, it goes way beyond health and local authorities. The buy-in from the voluntary sector, from other parts of civil society, is absolutely enormous.
Yeah, that sounds like success to me. That's great. Thank you very much, Richard. That's fantastic. And I'm sure there will be lots of questions for you later on. But for the time being, I'm now going to come over to Kevin. Hello, Kevin.
Hi there.
Hello. Hi. Over to you.
Thank you very much. Good morning, everyone. A little bit of a personal introduction. Like Richard, I've got a background in local government. I was a CE in Newcastle and in Cornwall, but also in background in technology as well. I set up the digital company Agilisis, which is still going strong today, and ran Circle's global technology business. Also spent 9 years in New Zealand running the capital city there, Wellington. You probably tell from the accent I'm a Geordie. Being a Geordie, I carry the burden of supporting Newcastle United Football Club. 68 years without a domestic trophy. So I'm used to dealing with adversity, and I found that quite useful in my job here in the ICB in Lancashire and South Cumbria. I'd like to begin with a Swedish proverb. Rough waters are truer tests of leadership. In calm water, every ship has a good captain. And my goodness, the NHS waters have been very rough in recent times, haven't they? We have got a £4.5 billion budget, suffering from my New Zealand there, which is largely delivered through the acute sector. Over 60% of our budget is spent through the 4 acute trusts in our area. What are the key drivers of health and care? If you look at the population, it's the over 85s with multiple long-term conditions, a generally aging population, a growing population, increased demand because there's a lot of innovation going on across health and care, and new solutions are arriving all the time. COVID and long COVID, poverty and the cost of living crisis. They're the sorts of things that are driving our health and care spend. Lots of big challenges, but lots of opportunities too, which I think both Graham and Richard have reflected on. We've got 2 new hospitals in the new hospital programme, which should open their doors in 2035 if all goes well. I know it's a long way off, but actually planning for that sort of scale of investment needs to begin right now. We need to make sure those 2 new hospitals are the right size for the future, not for the future needs, not the current needs, have the right clinical model, the right community and the right primary care model for the future needs, not the current needs. And all of those changes have to happen simultaneously and well in advance of 2035. And our population is aging, and our most expensive group of frequent flyers are those over 85s with multiple long-term conditions. That group's going to double over the next 25 years. The 3 standout growing diseases, this is the Health Foundation's report, not me speaking, are chronic pain, diabetes, and anxiety and depression. All of those are going to require a lot of action in primary care and in community settings rather than the acute system. And if we kept our current delivery model of 60% acute, 40%, we'd have to pretty much double it with those population changes over the next couple of decades. And no political party, whatever their priority for the NHS, would be able to deliver that, which means we've got to get into radical reform of our system. Now, as an ICB, we hit the ground running. We made an early call at our very first meeting on changing our place arrangements to be co-terminus with local governments. We've got a completely new team at the ICB. We were one of the first movers in having a Mars scheme to trim our numbers. We had 55 senior people leaving the organisation because we have these headcount targets we have to live with. We brought in Ruth Carnell to look at our operating model to make sure that we weren't duplicating with the providers, etc., and that we were getting good use of taxpayers' money. We've in-housed quite a range of services from the CSU because we had 8 small CCGs who needed a lot of help, but we're one quite big ICB that can do it ourselves. We produced a pretty honest state of the system report, which identifies a whole range of problems and challenges we face in our patch. We did deliver a balanced budget last year. but we've got a very difficult challenge this year. We've agreed a planned deficit with NHS England, and actually we've said the reforms are so significant, it has to be a 3 to 4 year programme, which they've agreed with. And we've got formal recovery arrangements that we're putting in place to deliver that reform programme. We've got a major devolution programme to place underway, and we are proceeding with some significant reconfiguration of services, community services in the Blackburn with Darwen area, and quite a big change to continuing healthcare, which is a very major budget, well over £300 million a year. It's almost the size of a medium-sized hospital. In terms of what could we do to be smarter, faster, better, and cheaper as a health and care system, I think we need to look at the long term and the short term. In the long term, if you had a blank sheet of paper, would you really have 7 elective care centres, 6 A&Es, 5 separate expensive old world sets of support services? Would you spend £300 million on temporary staff at premium rates? And would you be spending most of your money on acutes and actually relatively small amounts on community? So there are great opportunities, I think, for clinical productivity improvements and reconfiguration, but we do need to make sure that we push that new model. One of the things we need to do is really invest in community and primary care. What are the sorts of things we're looking at? A huge expansion of virtual care. We need to be thinking about a virtual hospital rather than just virtual wards. And it probably needs to be on a scale that's bigger than our 4 hospital trusts at the moment, to cope with the sort of aging population challenges we have going forward. There are some great examples globally in Australia, but also now in Saudi Arabia. They've got a virtual hospital there. It supports 130 hospitals. They offer more than 30 specialised services, and they deal with more than 400,000 patients a year. So it's on a significant scale. At the moment, our virtual ward programme is expanding. By the end of this fiscal year, we'll have something like 750 virtual ward beds in Lancashire and South Cumbria, but it's pretty low tech. We don't really use much technology in that. Each hospital has got a different platform. The levels of utilisation are very low in some cases, in the low 30s, and very high in one case in the high 90s. So there's massive variation across, and I don't think we're always focused on those patients who are most at risk of being admitted to hospital too. So there's a lot to do, and I think we can do a lot better. That's a good example of the opportunity for productivity improvement. We also need to develop the sort of integrated care centres that we've seen elsewhere in the country, and we have got some local examples in Lancashire and South Cumbria, Healthy Fleetwood being a great example. But the one I'm going to use is from the Hull area, the Jean Bishop Centre. It was mentioned by the Secretary of State at the Confed conference, for those of you who were there. It's a great example of admission avoidance, providing a central hub for NHS, social care, voluntary, and even fire and rescue services, because the fire service don't really put out that many fires these days, but they do spend a lot of time going into vulnerable households, helping them and making sure they've got appropriate fire prevention systems in place, and therefore they deal with quite a few vulnerable people that we don't always deal with in the NHS. And basically what Jean Bishop is about is proactively and reactively identifying those frail elderly who are at risk of hospital admission, making sure they've got appropriate care plans and medicine plans, etc., and keep checking them. And they've had great success, quite a big reduction in emergency attendances by that group, and significant reductions in attendances from patients in care homes as well. And they've started to roll that across the whole area. So that's the sort of thing we're very keen to do in Lancashire and South Cumbria. Another area is the expansion of intermediate care, step up, step down. accommodation to make sure that people who are in hospital with moderate health needs can actually go back into the community well. We've got a couple of examples in Blackburn now and Preston, where we've got just a bit over 100 beds actually in Preston, and plans to open in a few weeks 38 beds in Blackburn with that in mind, and that all helps flow and reducing not meeting medical criteria to reside numbers as well. Clearly, another area is to start facilitating the transfer of money to some of those community programs and prevention, again mentioned by both Graham and Richard as well. So we're very keen to do that. Some of the areas that we're pushing very strongly now are smoking, suicide prevention, and hypertension and blood pressure. So some really clear examples there. We're like the other two systems, we're financially troubled, and we've been troubled for decades. It's not something that's new, that's happened in the last couple of years. Pre-COVID, we had deficits of 170 million across our system between the acutes and the CCGs. And during COVID, we got lots of one-off monies, which were used to create extra capacity, which has got ongoing costs, and that added to the deficit, if that makes sense. That's the underlying. And then on top of that, we've got inflation, we've got, particularly in prescribing in areas like CHC packages, which have added to that, and we've had strikes, which also have significant costs to the system. So very, very challenged financially, and what we've done about that is we've got a real strong focus around recovery and transformation, and we recognise that can't be done in 12 months. It has to be done over a period of time. So we did agree a planned deficit with NHS England. It's a lot less than the real underlying deficit. So there's a lot of activity trying to keep the system in balance as we go forward, and it's a very, very challenging time. We voluntarily adopted at our first board meeting last July to have all of the NHS England controls that you would expect when they intervene in a trust around discretionary spending, vacancy controls, etc., etc. But it is a very challenging time, and you could say, okay, well, finance is a big barrier, and it is a challenge for us. But I think leadership and culture is also a challenge for us too. We're in a system where we've had relatively low turnover. The big cities of Liverpool and Manchester do have more turnover than we have. And many of our leaders haven't really had the experience of delivering the sort of scale of reconfiguration that we're going to have to go through going forward. We've got a good plan, but it's a high risk plan with a lot of big changes which will have to happen simultaneously. So execution of that is going to be hugely difficult. So it is a real time, as Graham was saying right at the beginning, for real leadership. And I'm really keen that we strengthen the capability of our leaders, that we have strong leadership development programs that are really focused on the issues we face in our patch of, how do you do reconfiguration? How do you make sure that you talk to the local communities well in advance so they don't hear about it at the last minute and then start objecting? How do you actually convey and deal with the wider public about the need to move from an acute-centric system to a community-centric system, and some of the things they will be used to doing in going to a hospital, actually in future they'll go through primary care or special local service centres. In a way, it's a daunting agenda. I think we do face massive challenges, and probably the biggest issue for me is how we deliver stuff at pace and deliver it well, which is why I'll end with a final quote from the first US president, George Washington. He said, "Well done is better than well said." Thank you.
Lovely, thank you, and a good note to end on there. Can I just pick up a couple of points with you, Kevin, around capital, I think, really, because at the Confed, we're calling on government to review the amount of capital funding and the allocation process in the NHS capital regime review. But you've talked quite a bit about that shift from an acute-centric model to a community-centric model. So I just wondered if you could talk a bit more within that context.
Yeah, I mean, really backing up what Richard said about how we do finances. Capital is really severely constrained in the NHS. We don't operate as a normal business would. If you're in any doubt about that, I'm very happy to show you around the Royal Lancaster Infirmary or the Royal Preston Hospital. They've been starved of in serious investment for decades. Services are still delivered out of a lot of old Victorian buildings that aren't fit for purpose. There's a massive backlog of maintenance, and the costs are going through the roof, to use a pun. And across the NHS generally, there is a massive shortfall in terms of basic maintenance and the quality of the state. And that is expensive. It means we are bleeding cash in terms of maintenance, because those maintenance costs are very high. And there's far too much reactive and far too little planned, which is an inefficient way of operating. I think also in terms of the way capital is allocated to ICS areas, it generally tends to come down in little pockets here and there around specific national priorities, which might not always be a priority for the local area. I think we need a single pot so that we can match the capital and the growth priorities to what's important in our area. And I also think there's an issue where you're competing for a constrained pot of capital money nationally. You make your case. I mean, we've got a decision at the moment. We've just supported a centralised pathology service for Lancashire and South Cumbria instead of operating it in a decentralised way. It's a 50 million investment. It produces a 20 million annual saving. So it's a complete no-brainer. If you were operating in the private sector, you'd have no trouble getting capital for it. But we were offered through the system 30 million, so we're 20 million short. We have roughly 100 million of capital, so we're going to have to reprioritise. It's nowhere near enough, and that's a complete no-brainer proposition, which will help our recovery plans that I was talking about earlier. So that's a great example, isn't it? I think just a couple of other things I would say as well. We've got probably a few notes of caution. I mean, I do worry sometimes about the way we do business cases in the public sector generally and the NHS. You get a consultant in this, or a team of consultants. They'll produce a big plan. In order to get through that constrained pot, you've got to make it really attractive with fabulous returns, so it gets then signed off. And then the poor sod who has to deliver it gets the plan and says, well, this is not going to be possible. I need more money and I need more time. And you know, I guess that was an element in the high-speed link, wasn't it? It was probably an element in Channel Tunnel, and it's going to be a big challenge for the new hospitals programme. We've got 2 new hospitals, so that's going to be a big issue for us. So I think the way business cases work is actually a big issue here. I think also it's about recognising the full life costs of a project, because you can often get a new centre in, but it actually, there are financing costs around that, but it also generates new service requirements, and they're not always considered. So that would be the second thing I would sort of talk about there. And final observation would be, if you think about our story, and it's the same general tenor for the 2 other systems in the Northwest, of moving to a community-centric system, I do worry that you can invest all of these things in things like the Jean Bishop Centre, but such is the pressure that the NHS is under that actually it doesn't release capacity in the hospital sector. It does reduce admission avoidance, but the beds still get filled up because there's so much pressure on the system. I think that's a real worry.
Thank you. Yeah, really, really helpful observations. And just as I asked the other panelists, could I ask you what you would describe as your system's biggest success from the last 18 months?
I think it's not a lot, you know, the agenda we're addressing is a long-term agenda, so it is difficult to sort of show demonstrable progress. But we did make a big call at our very first ICB meeting to change our place arrangements. They were based on 5 hospital catchment areas, and we moved to coterminous boundaries, which I know the other 2 systems already had. But that was quite a big call. It was the right thing to do. There was quite a bit of opposition to it. So it was a brave decision for the ICB, but it's the only way we can. If you were Lancashire County Council, you were in 5 different place-based partnerships, and there was absolutely no way you were going to do any integration with the health service in that scenario. Now we've got 4 place-based partnerships at the principal local authority level, and we've got a 3-year devolution plan that's been signed off by our ICB board, and we've already got some areas like population health going down. We're rolling out integrated neighbourhood teams across the whole patch. So there's real momentum building, but that would be probably the one. And places got to work if we're going to make our system community centric. So it's absolutely critical to it.
Okay, thank you. So I'm going to hand over to Helen now, who's got some questions for the 3 members of the panel, and then we're going to come to audience questions. So if anybody's got questions they'd like to submit, please do pop them in the chat and we'll come to those fairly soon. All right, thank you. Helen, over to you.
It feels like I've sat very quietly for a very long time, so it's been fantastic to listen to the presentations and to think about that in the context of the questions that we were going to put to the panelists collectively. Because so Helen and I have worked together to think about how our State of ICS report so indicates the position that ICBs and ICPs find themselves in at this point. The respondents that provide the insight for the report are the senior leaders from ICBs and ICPs. We're also mindful that this session is about opportunity and how we leverage opportunity. So we tried to think about what came out of that State of ICS report as being key areas of development and where there might be chances for us to do things in a different way and utilise things in a different way. So I'm going to try and get through a few of those questions and put those across to all of our panelists. And I think what I'm going to start with, given the last part of the last conversation was something around kind of transformation in terms of community and making things much more community centric, is a conversation about data as an enabler. So NHS Confederation have recently produced a report that looks at the value of community providers and what's brought into the health and care sector by those providers. But it was clear in a discussion about that we didn't have necessarily the same amount of data about services in the community as we would have for services at the hospital, and that sometimes it was more difficult to have conversations about their value because we didn't have that same information. What I wanted to ask of our panelists is, what part of your system delivery would you like to understand better? Is it about access? Is it about outcomes? Is it population health management data? And how could you make best use of that data in shaping some of your intentions and strategies? So I'm going to come to Graham first as the person who spoke first.
I need to come off mute. Thank you. So I think data has to drive what we do. And I think we could characterise the NHS as being too much about reactive healthcare and not enough about proactive healthcare. And slowly and systematically, the NHS has been making inroads to this for a number of years. So public health specialists can tell us how many people you would find in any given population with diabetes. Yeah, for something like 10 or 15 years now, we have been financially incentivizing GPs to actually have an up-to-date disease register and the active management of those patients. Well, if you get that right, you actually minimize the people who will present with unstable diabetes at hospital, who will have falls, who will have admissions to kind of stabilize those lives. And so it's not just about the data itself, it's about using that data proactively and actually creating the space for the people who work in it to do those things. Now, I use the example of diabetes because it's something that we've been incentivizing for a long time. But the other thing for me is Cheshire and Merseyside have something called CIPHA, CIPHA, which is kind of combined intelligence and public health or population health action. I've probably got that acronym slightly wrong. One of my colleagues will probably put in the chat what the correct acronym is now. But it's the way that we can overlay the different data sets. So yes, you're right, there's a paucity of information in community services. It gets better all the time, but actually writing back whatever community services do into the GP record, giving us that combined source. But if we're talking about true proactive healthcare, we need data on how many times somebody is truant from school. We need data from the police on how many times that they might respond to a particular family or get a call out into a certain place. So again, if you look in the Liverpool system and with Merseycare, the work that people are doing under the banner of complex lives, you would find that the people who are using whichever NHS service the most might also be the people who the housing association are trying to engage with, the police are trying to engage with, the schools perhaps are also struggling with. So recognising that we have a common desire to help and support the population we serve, and increasingly finding ways to share data about people's use without betraying their confidence is our big challenge.
Thank you. Kevin, I can see that you're nodding along there. Is there anything that you'd want to add to that?
Yeah, I mean, I read the report about the community stuff, basically saying there was less rich data in that area, and I would agree with that. But I think the main issue is we've got lots of data, but we lack insight. And if you look at the way the private sector work in terms of marketing, what they do is they really segment the populations, and then they are very, very proactive. And we've got some great examples, and my little story about Jean Bishop is a perfect example of that, because what they're doing there effectively is looking at that over 85 population. They're looking at their risk of admission from, if you like, low risk at 0, very high risk at 10. Then they're proactively looking at the 8s, 9s and 10s and making sure that there are carers. And I think that's the sort of thing we just need to do a lot more of as a National Health Service going forward. But there are brilliant examples all across the board, but we need to level up and really do it at pace and at scale.
And Richard?
So kind of a subject dear to my heart. Allocative efficiency is one of my favourite pairs of words, and I was involved with the Hewitt review, and in the finance and productivity side of that, looked at quite some detail at different payment mechanisms, incentives, and so on. But I think generally came to the conclusion that a lot more work needed to be done on that. I know there is a working party that the ICS Network is set up to be looking at precisely at that. I think, first of all, I think in this question, we need to know what problem is it that we're trying to solve. And so we've developed a segmentation of our population, which says that if we do nothing, in 5 years' time, we'll be spending more on mental health in the working age population than we will on frailty in the over 65 population. A fairly fundamental change. But if we know that's what's going to happen, then it is planning the interventions that will try and reduce the prevalence that we're aiming towards. There comes the issue. I go around, I see lots and lots of wonderful examples in community settings of that preventative work, lots of enthusiasm, people really committed to what they're doing. What I can't answer, what they can't answer is, with all of these things, is why should we put money in to program A rather than program B, because we don't have actually basically the analysis that allows us to do that. So I think what we're trying to do is work with the Applied Health Research Centre, which is based at the University of Manchester, is to start develop the programmes that allow us to evaluate the efficacy of the different programmes so that we are able to make those choices. Because if we are going to get upstream, it does mean that we have to allocate resource in a different way, and we need the evidence to do that. And frankly, in most cases, we haven't got the evidence at the moment. I was looking at Music in Mind program the other day. So working largely with people with dementia, it clearly makes a big difference to their lives though. But could we put a value against that? No, it's really, really difficult to do, and we need to do that. And I guess that's the other thing in the world we're going into, is we have to look at as much at non-clinical interventions as we do clinical interventions, because actually 80% or plus of what we need to do is going to be non-clinical. Clinical interventions almost come when it's too late, when we fail to prevent. So we really need to look more seriously as a partnership. And that's what the partnership allows us to do. It allows us to look at those things outside the health and care system that are really important to improve population health.
And to me, that feels like a really important theme that's come out across all three presentations, is around that kind of stepping into more social solutions that respond to the various needs that people have in their life, rather than those kind of clinically based solutions. It feels like that's a really clear narrative point that's come out across all of the different presentations. I feel like one of the other key things that's come out across the conversation is around sort of being able to do things that respond specifically to local populations. So something in that about data. I was really struck by what Graham said about the women's health work that's been taking place in Liverpool, and how it's through identifying in a local footprint that there is a specific issue that you can take a different set of actions that meets those particular needs. What I was going to reflect was that from our State of ICS report is that some of the confidence around delegating to place has actually reduced in the second year of ICBs, and that's probably because we're living and breathing it now, and trying to actually work through the things that make delegation work. But what I would be interested to put to you as a group is, how do you feel systems and places can work more closely to ensure that there's mutual readiness for delegation of functions and decision making? I know that in Greater Manchester there's already a great deal of progress made around that particularly, and there's been place conversations in all of the work. So what opportunities do you see might arise through greater delegation, both for the system, for the place, and for others? Richard, I might come to you first on that, because I know about Greater Manchester's position in terms of place-based working.
Specific question about what comes out of that is that, first of all, if even on the size of our neighbourhoods, so they're pretty big really, 30 to 50,000 people. But if you look at the demography of Greater Manchester, needs in different areas are fundamentally different. So one of the things that delegation allows us to get away from is one size fits all, because one size doesn't fit all, and to be able to design solutions that are appropriate to different communities. So, and that is probably actually the biggest offer. And it's also it allows people on the shop floor to take control over what they are doing, and to be able to give that sort of direction. So I think it increases productivity, it increases morale. There's work to do to give people confidence to do that. I think what that has to go alongside that, though, and a couple of our place-based leads, 8 of my place-based leads are local authority chief executives. I wish it was 10, but it's 8. But one of the things that those that, if you like, a little bit behind the Greater Manchester curve have said is why don't we standardise? Why haven't we got? Why do they have to keep reinventing the wheel? Why can't they just simply be looking at what other places are doing and adapt it for their own circumstances? So coupled with that freedom and flexibility to respond appropriately to local circumstances, there also needs to be a gathering of what is doing and see what will be relevant, what is scalable, and what can be used in other places. At the moment, I think we're better at the innovation than we are at gathering what the innovation is delivering and spreading it. And we need to get better at spreading it.
And I definitely think that's something that Confed can help with as well, is that kind of capturing of some of the great work that's happening and showcasing in that, and helping to kind of create a bit of inspiration. Graham, how do you feel about how the kind of place and system are working together, and what kind of opportunities do you see?
Okay. I want to go back, Helen, and challenge the presumption in how you first answered the question. And the presumption was that delegation has got worse. Well, what I want to say to you is, we are still in a really unusual situation post-COVID. So rightly or wrongly, NHS providers, our hospitals, effectively went through the key COVID period operating as if they had a blank check. So all of the financial systems were taken away and places were funded out to them. Now, as the NHS is gradually coming back from that, there are elements of the financial system that are still funded in a particular way, because the government wants to see the elective recovery programme delivered and done in a different way. So we don't have the normal financial flows in our system that we had pre-COVID. I think there's also an issue about when you abolish CCGs and you create ICBs, there will be some people who will grieve for the past. And these things take time for us gently to move forward. So when people talk about, well, we're delegating less, well, of course we're delegating less than when we had 9 CCGs, or in Richard's case, 10 CCGs, because that is effectively the legal basis and has changed. And we have to move through that. The other thing I want to say to you as well is, at any point in time, any organisation, whether it's a commercial organisation, whether it's a charity, whether it's a public services organisation, goes through phases of centralisation versus decentralisation. And these things are based upon confidence and the context that you work in at that point in time. When the risks in the system are very high, all organisations have a natural tendency to centralise, when actually most of the solutions can be found through decentralising. And we hold on to this idea that says we want as many of the decisions made as close to our patients and communities as possible. So you probably find all of us believe in the notion of decentralisation, but actually it's the context we sit in. And if I can also just finally address that point about people grieving for the past, one of the things for our places is not just about saying, who is it who has the hand on the checkbook? Who is it who has the budget? One of the things that we expect from our places and our place leadership team is a huge premium through influence. Actually, how they convene the local system, how they get parts of the local system to work together to share their collective assets and resources and use those effectively together. So let's not always confuse this with budget holding. Decentralisation, place-based leadership is often about the softer influencing they can do and the softer powers that they have. And a bit like something Kevin said, you know, it's how we develop the skills of our leaders in that system when they worked in a system where they were taught behaviours like this for the last 30 years. We've got great people who work for us, but we have to help them with new sets of skills.
That's fantastic. Thank you, because that's a really helpful reflection on that result where it was kind of where there was less confidence in delegation. Actually, that's probably a really reasonable thing for the context in which we find ourselves at this moment. Kevin, is there anything that you're wanting to add to that?
Yeah, I mean, all three systems are really trying to push this community-centric approach to health and care going forward, aren't they? And that can't happen at the ICB board in our headquarters near Preston Railway Station. It has to happen in a real place like Blackpool or Blackburn, doesn't it? And to me, it also has to have that double devolution down to that neighbourhood level, which Richard talked about as well. So it's not just about going to places, it's about that double devolution that goes on. And I strongly agree with Graham. I think culture and leadership is far more important than financial delegation. We're consciously going to delay our financial delegations next year to place because we want our finance team more focused on all the recovery stuff that we need to keep the organisation safe as a whole. It's not that we're against financial delegation at all. It's just looking at the competing priorities going on. But I think there also needs, for all this to work, it's got to be about pushing the integration agenda, hasn't it? And to push the integration agenda, and there's a lot more of that really in the two other systems than we have in Lancashire and South Cumbria. I think the big challenge is the elephant in the room, if you like, is the cost shunting that happens both ways between health and social care. And I think we've got to, we're certainly starting to have grown-up conversations around how we manage our way through those challenges. We've got good examples in the patch where you've got really good, up-to-date cost-sharing policies for all the relevant areas, and in other places there's nothing. So that's something, that's a foundation for doing the place stuff well. So I think that for me is a critical area, and it's relevant for the money, both for local authorities and for the health service itself.
Thank you. I'm really mindful that we've got some good questions in the chat, particularly around primary care and productivity and around multi-agency partnership working. So don't want to spend too long on our bit when there's other really valuable stuff to be asking about. I think one of the things that does cross over, though, in terms of questions that we've thought through and the questions that are coming out, is about kind of multi-agency working and creating the right relationships that enable, because I think we would all agree that actually it's really strong relationships that enable you to achieve changes in the way that things work. So I guess one of the questions that I'd want to put forward to the panel is about how ICBs and the system more broadly can work to maintain really good quality relationships and where it feels like those are evolving. So Kevin, could I come to you first on that, about that kind of maintaining good cross-sector relationships?
I mean, like the other systems, we've got a whole range of formal mechanisms where we have representation on our boards from, the voluntary sector, from local government. I mean, we've got 4 members on our board representing different parts of local government. For example, we've got primary care there, we've got the acute trust. So I think all of that formal level, but fundamentally it's about culture and leadership, isn't it? And it's about, we're going to have some leadership development programs in our system, and I want to make sure that the leaders from local government and the voluntary sector are part of that. It's not just a health thing, and I think it's just picking examples like that and doing more of it, isn't it? Really, and it's about finding there's a craft, isn't it? The craft of leadership is to get a few things over the line, build your confidence, do the more difficult things. And I think that's what we've got to do as a system. And I think all 3 of us have given some great examples of that happening, haven't we? Which are those cross-functional things. So, pick a few things that really work and then do the more challenging things as you move forward.
Graham, is there anything you'd want to add to that?
You can't work in partnership unless you first got a relationship. And one of the things that struck me, and this was based on a lot of advice that I received, but I was newly appointed as the chief executive to the ICB. I was not working within the forerunner to the ICB or any of the previous CCGs. And I changed virtually all of the top team following my appointments, and also a good number of the leaders in our place-based partnerships were changed as well. Yeah. And if I reflect back to my interview, there was a local authority chief executive on my interview panel. There was a hospital trust chairman on my panel. There were various other partners. Every place-based director I have appointed, I have put myself in the minority on that interview panel. So, you know, there have been a couple of representatives from primary care in that place. There has been the chief executive of the council and at least one elected member from the council. So the choice of the people who are leading each part of our patches were chosen by people within the place. I kind of had a power of veto on that because I wasn't going to appoint anybody who wasn't above the line or up to the standard. But you share the decision making to build the relationship and build the trust.
Thank you. And Richard?
Well, I'm not to repeat what Graham and Kevin have talked about, other than to add that, yes, relationships are important, but that means you have to invest time in your relationships. It doesn't. But what I really wanted was to take the, I'll say, culture, values, ways of working, behaviour theme. We're not going to have a common set of values across all of the stakeholders, and all the organisations will have their own set of values, although I suspect if you look at them, there'll be an enormous amount of similarity between those statements of values. Ways of working is something you can do something about, and effectively across all of this, you don't need things to be identical, but you do need some commonality, and in particular you need partners that when we're using a particular words, that we all mean the same things by those words, that we all have a common view about how we work. So what we've instituted coming out of our governance review is some work that's being led by the chief executive, which is I think right, about having that discussion about culture, values, behaviours, ways of working across the whole of the piece. So at the end of the process, we can come up with that commonality of how it is that we are all working together in the same way.
Thank you ever so much for all of that fabulous insight. I think now what we'll do is we'll move to questions that have been put forward by attendees. I know that there's a couple of people who are set to raise questions. Helen, do you have who's set to go first?
Well, I'm going to read out Julia's question first, and then I'm going to come to David and then to Grenville to ask those questions in person. So Julia's asked, why do you think the North West is more challenged to regain productivity than other regions? Is it linked to deprivation levels of the population, or are there other factors?
I don't know whether it's me, but I've lost sound. I can't hear you now, so I'm going to try and answer that question in the hope that you can hear me. So one, our public health colleagues would tell you that the Northwest had COVID worse than any other part of the country. And one of the reasons for that is attributed with the interconnected notion of our populations. You know, the type of housing stock that people are living in and the way people live their lives. So we had COVID worse, which was a challenge. Secondly, we have suffered more industrial action than other parts of the country. Now, the doctor's strike may have hit more uniformly, but when we look back at the strike action from other groups of staff, There was one occasion where there was industrial action in March, where just in Cheshire and Merseyside, I had more organisations affected by strike action than the whole of London, than the whole of the southeast of England. Yeah, and we should absolutely respect our staff's right to be part of the trade unions, and we should absolutely respect their right to take part in legitimate strike action. But that has had a consequence on the productivity and the work that we are able to do. I'll stop there because I didn't hear the full question because my sound has gone off. So put the next question to somebody else and I'll see if I can sort out what's happening.
All right, thank you, Richard. Yeah,
just add something to that, and clearly deprivation is a factor, and demography is a factor. So the demography of the northern half of Greater Manchester, similar to East Lancashire, similar to actually parts of West Yorkshire as well, and the impact of COVID in those communities has certainly had a very significant impact. And we know that deprivation is the biggest single driver of health inequality. So I think that is a factor. The other things that Graham's talked about, I agree with, but something Graham talked about earlier is kind of the COVID spend free-for-all that we had within the acute sector. And certainly, I say in Greater Manchester, our colleagues in the acute sector still cannot fully explain everything that they spent that money on, that they are still spending that money on. Some of it we know. So, for example, extra wards were opened to respond to COVID. All those extra wards are still operating, and they're unfunded. And the reason they're still operating is because they're full, which might also a quick plug for social care. One of the reasons that they're full is because social care, if health is underfunded, social care is really underfunded. I throw that in, but I think really we still cannot fully explain why and where that money is being spent, although we are currently going through that process. And certainly, if we're having this session in a year's time, if we can't explain by then where it's all gone and what we're doing, then I'll be very worried indeed.
Kevin, did you want to add anything to that question?
Yeah, I'll just add, I think culture and leadership is part of the issue, frankly. I mean, we're making rapid progress now in our area, but over a couple of decades, we avoided the difficult issues. There were some obvious reconfiguration opportunities that would have improved productivity dramatically that we didn't take. A perfect example in our patch is pathology. It's been bouncing around for 7 or 8 years, and we agreed as a system a few years ago that we'd have a distributed model. When a centralized model, the business case was so compelling. But the trust wanted to, if you like, retain their independence and but that's the sort of thing we've got to break through and be brave about. And there are lots more examples like that.
Great, thank you. So David, you've asked a question in the chat. Would you like to unmute yourself and ask it directly to the panel?
Right, yes, thank you. I'll phrase it a little bit differently now I'm asking in person. I'm a non-executive director on the North West Ambulance Service, which, as you'll know, covers part of the North, Cumbria and North East ICS, and that's the ICS I live in. I live just outside Carlisle. I assume my question isn't just unique to my ICS and covers the other ICSs. If it doesn't, I do apologise. I've seen almost total collapse of access to GP services comparing post-COVID to pre-COVID. It's just been massive. In general, that caused a lot of anxiety to local people, especially elderly people who are really worried about it. And it clearly has impacts on other parts of the system. So, for example, a former neighbour of mine has a heart condition. About 3 times in a week, she had particular issues with the medication. She couldn't contact the GP. 3 times instead, an ambulance was called out. 3 times she was taken to A&E. In the old days, I'm absolutely sure the GP would have come out to a house, would have resolved it, and wouldn't be need for the ambulance trip. This elderly person going A&E 10 miles away and back again. So I guess my question is, and I know it was sort of touched on in some of the discussion previously, but I just wondered, how will GP services be got back to where they need to be? And I fully understand that might not be where they were before, but where it needs to be, because clearly, certainly where I live, it's nowhere near it needs to be.
Great question, thank you. Graham, shall I come to you first?
Access to general practice is variable. There are some general practices out there that are providing absolutely fantastic access. Patients who can get appointments on the day, patients who have a variety of sources of access. What we know is it isn't uniform. What we know is, despite all of the financial challenges, and this comes back to a brief reference that Kevin made earlier, to kind of penny packet and silo-based funding, we as ICBs are getting ring-fenced funding to invest in a significant primary care access recovery plan. And certainly for Cheshire and Merseyside, there's about an extra £90 million that's going to be spent in the remainder of this financial year to bring about those types of improvements. I think the question isn't just about traditional access, though. The question is also about how we modernise primary care. Now, when we had the productivity question earlier, and some of our hospitals are still not doing 100% of the number of operations that they were doing pre-COVID, our GPs and our primary care partners can prove to us that they are doing something like 120% of the activity that they were doing pre-COVID. Now, admittedly, that now includes a count of things like telephone consultations, whereas previously it was kind of all very much face-to-face and only face-to-face. So the model is changing. But the number of practices that now offer online consultations, that have a wider and variable primary care team, but that's the other really important thing for us. You know, you talked about somebody who was having problem with their medication. An awful lot of our GP practices now have a retained pharmacist within their GP practice team to effectively, you know, do and help with issues like that. Now, it's not uniform everywhere, but there's also a big public comms campaign here to help people understand what the offer is. I'm sure my colleagues will have more to add to that.
It's very fresh for me, David. But we had a board meeting on Wednesday, and two of the papers on that, one was about the primary-secondary interface, and one was about access to primary care. So first of all, I think we need to put it in perspective. And if we look at accessing Greater Manchester, satisfaction rates are 92%, dissatisfaction is only 4%. So yes, there is poor access in some cases, and it's quite often well publicised, but it is a relatively small amount. Most people are seen, 70% of people are seen face-to-face. A lot of people now opt for digital or opt for telephone. I certainly would do most of the time, and most people are seen on the same day as well. So whilst there are access problems, you need to put them in perspective. I think, having said that, what is being done about it? Improvements in digital telephony will work, although discovered there that early movers in digital telephony don't have always the functionality they need, and the money that's available is only for new take-ups, not for people who need to improve their systems. So there are issues around that. The NHS app has suddenly become quite useful. I was looking at it just the other day. And now, for example, I need to change my pharmacist, and I can now do it online using the NHS app. So there are things that will make it easier for me as well as easier for GPs. We are moving to allow consultants in the acute sector, that when they're seeing a patient that needs referring to another consultant, they can now do it directly rather than having to refer them back to GP. Well publicised greater use of community pharmacy, which again I think will a lot of this is about taking the load off GPs in order for them to be GPs rather than a whole range of other stuff. And the same is also having larger multidisciplinary teams operating at the very smallest on a primary care network, and a lot of the planning at a primary care network level, again, so that we get GPs doing what GPs need to do, and a whole range of other professionals can provide the services that patients or potential patients need. All 65 PCNs in Greater Manchester have a capacity and access and improvement plan, using, not identical because they're all different, but using a similar template. So even in a relatively good situation, they're looking to improve that. I guess the last thing I would throw in here is workforce. Clearly, there are issues with workforce in across primary care, and again, there is a system level, a workforce plan about how we can first of all retain the workforce that we've already got, but also seek to increase that workforce over time as well.
Could I add just a few words there? Look, I completely agree with everything that's been covered. I think there is this theme of lifting the burden off the GP so they can focus on the GP work. So more allied health professionals, better technology, more integrated neighbourhood teams, more use of pharmacies to do simple prescribing going forward, gearing up care workers, paying them a bit more so they can do basic medical checks, all these sorts of things. And we've got examples in all three areas doing this, and we do get funding from the NHS to do that. But I think you are right, David, that the pressures are immense at the moment, and we're struggling to keep pace with demand. But again, like everything else, there are lots of opportunities. There's still too many people going through who don't really need to see a GP. They could see a nurse or a pharmacist, etc. So I think there's still lots of opportunities, but totally recognise that the service is under severe pressure. In our area, we're an above average performer where the bar is too low, because standards have slipped back, but I recognise what you're saying.
I think that the next question that we have is coming from Grenville. Are you available to come off mute and ask your question?
Yes, thank you very much, Helen, and morning, everybody. Fantastic session so far. I've changed my my question because quite a bit of it has been answered in the discussion, so I'm going to change the thrust of my question. Graham, Richard and Kevin have all spoken very passionately about the importance of going upstream and the opportunities of working in different ways with the voluntary and community sector and housing providers. I would also add in there possibly leisure trusts and also multi-academy trusts and the schools and even businesses around the work that they can do in terms of reducing the escalations and the avoidable flows into our hospital facilities. And each of them also in their own different ways have talked about some of the barriers that we face to some of that in terms of the financial frameworks, the accountability structures around the way staff are deployed, around data. I'd also add in sort of regulatory regime possibly, and still some cultural differences. So the question is, if we really recognise the importance and the opportunity, and I think some great stuff is being done. I forgot to mention at the beginning, I'm a non-exec director at the Christie. I also chair Viaduct Care, which is the GP Federation in Stockport. I sit on a housing association as a non-exec, and I chair a multi-academy trust on the borders of Greater Manchester. So my question is, how can we actually supercharge the pace of that transformation, given that that is probably going to provide some of the solutions and some of the efficiencies to the big financial challenges that we've got? So in my mind, we can't afford to let that drag because the opportunities are so big, but I do appreciate the significant pressures and tensions in the system.
Great question. Kevin, could I come to you first on that sort of supercharging this activity point?
Yeah, look, I think it's a great area, and we've got opportunities now, haven't we, with the new procurement regime which has been enacted. But I'll give you a little example. We've got a social enterprise. It's headquartered in Blackpool. It was set up by 4 GPs about 25 years ago, called FCMS. Today, they employ 1,000 people. They provide services all over the country. About 50% is in Lancashire and South Cumbria, and predominantly we have 1-year contracts with them. So I think what we need to do is, with a really successful organisation like that, is get them to do more and get them to do it for longer, so that they, we've got too many voluntary sector organisations on short-term contracts. So I think there's a great opportunity there, isn't there? And I think just being brave. Some of this is about leadership, isn't it, Grenville?
Yeah, thank you.
Richard, Graham, is there anything you'd like to add to that?
Yeah, and clearly, I think Grenville, given that some things I've talked about, of course, Viaduct hosts the primary care board team in Greater Manchester, so I guess you'll know a lot about that. And I found myself yesterday at the Christie speaking at a conference about hepatocellular carcinomas and selective internal radiation therapy. Now, I have to say I know absolutely nothing about either of those two things. So I was talking about lung checks on car parks. I was talking about all the things you can do that are the non-clinical things to, first of all, detect in cancer cases earlier and preventative action. The answer to the question is that, first of all, there does need to be that assessment just about how important all of those things are. So this is about putting values against things. We've seen a massive increase in bowel cancer, which is largely down to poor nutrition, the increase. So again, let's equate what do we have to spend to make sure people can afford to get decent food against the cost of treating them because they can't. Similarly with housing. Enormous amounts of respiratory disease comes out of damp underheat. So let's start putting values about what that investment in housing would generate in terms of the health values. And of course, underpinning that is that all the various players you've talked about, it goes back to what we were saying earlier about relationships. We all need to be talking to each other, but we need to be talking to each other in a structured way. It's not like going down to the pub for a pint. And I think what the governance structures we've certainly put in place in Greater Manchester to allow those informal conversations to take place, but also a way we can have structured conversations with all of the necessary stakeholders.
So very briefly, we're making multi-year investments into the infrastructure organisations to enable us to help work with the sector more effectively. And then the other thing I want to raise is through general practice. There's a significant amount of money that general practice can draw down under the heading of something called the Additional Roles and Responsibility Scheme. Last year, that underspent by millions of pounds in the Northwest. And one of the headings on which GPs can spend that additional roles and responsibilities money is on social prescribing. And we've got a number of GP practices who we know have subcontracted that to leisure organisations, other voluntary sector organisations. So part of investing in the infrastructure organisations is to help them help us bring opportunities to people's attention and make that work.
Thank you very much. Helen, just one other comment, and I'd be interested if anybody wishes to contact me. In the Multi-Academy Trust, which is outside of Greater Manchester, one of the things I'm starting to have discussions with the board is about how we have a focus on the curriculum and change the curriculum to bring more exposure to jobs and skills and careers for our children, and also links into maybe apprenticeship pipelines, and also some thinking about early early healthcare messaging, and about developing that understanding at a young age about the lifestyle choices, because I think that is really important on the prevention agenda in terms of changing the behaviours and enhancing the understanding of lifestyle choices that younger people are making.
Can I well respond to that, but also with an example of things that are being done. I'll pick this example from Wigan, where there is a partnership between the local authority, between the foundation trust that operates in Wigan, Lee and Wigan College, and in this case it's Edge Hill University, to work with young people and local schools precisely to do that. But not only to motivate young people to understand what is available to them in the health and care area, and particularly the additional roles and responsibilities sort of posts that Graham was talking about, but also give them a very clear route about how they can get the necessary qualifications, which might be at an FE level, they might be at an HE level, that lead to real jobs that they can see. So I think there are really good examples of that, and certainly our aim is to be able to do that on a conurbation-wide basis, not just on, and it will be individual places doing it, but that's happening everywhere. There are good some really good stuff in Rochdale as well. There are some really good examples of precisely that.
Thank you.
Okay, thank you. So we've just got one more question from James, who would like to ask about mental health, and specifically mental health for men. And what do you see are the opportunities with the ICB and the ICP to address this and to support people suffering from mental health challenges?
Well, I'm waiting for one of my colleagues to go first, and they haven't stepped in. This Sunday is International Men's Day, isn't it? So I hope that my two colleagues have got a whole load of activity going on within their ICBs in the same way we have in Cheshire and Merseyside. And indeed, I attended a session just yesterday under the banner of State of Mind that was aimed purely at men, getting men talking and avoiding the consequences of mental health in men. Now, I won't get the statistics right on this, but firstly, there is a higher degree of prevalence of women who present into general practice with different levels of mental health, and there is an absolutely tiny rate of suicide in women. Conversely, there is a tiny rate of men who will present with mental health and anxiety problems. But actually, in men under the age of 57, suicide is actually the biggest killer in this country. So I thank James for calling it out. It is absolutely essential that this is front and centre of our minds, and it is absolutely essential that we plan our services and provide the opportunities and support for people. I only wish we were doing more. But again, I know we are doing a lot.
Thank you. Kevin or Richard, anything to add?
You first, Richard. Okay, I'll go. Society's changing, isn't it? We've seen a lot of sports stars, for example, men raising these issues, writing books. So it is starting to change. I agree we need to do more. We've got an improving mental health trust. We fully invest our mental health to the mental health standard. This needs to be an important part of that agenda. We aren't doing enough still. There's a lot to do. I think there's probably a big role for lived experience here rather than very medicalized approaches. I would have thought that would be a big opportunity in this sort of space. Richard.
Yeah, I think what we've inherited in Greater Manchester is historically we underspend on mental health, and we are in terms of the requirements to increase mental health spending, we've exceeded those actually since we've been in existence, but we're still some way behind what we would want to spend, and we are committed over time to rectify that. But I think also how we spend our money is challenging. Is we also have a disproportionate number of mental health inpatients in Greater Manchester, and one of the things we need to do is to move far more of that into coherent community settings. So we have to improve the services that we're delivering. So I talked earlier about our new mental health strategy, and in particular that's a social model, following on from what Graham was talking about, but also aiming to normalise mental health. So mental health isn't something stigmatised that some people have a problem with. It's something we all have. And I think getting it into that sort of position, I think will accelerate. I think what Kevin was just talking about then, and it is really mental health appears to be the one area in health that traditionally you wait until people are really at the end of the line before there is intervention. We need to reverse that, and as we seek to do with other things, try and get, if there is a requirement for intervention, it's as early as possible in the process, not as late as possible in the process. So I think there is a mindset that needs to go with that. And the question was particularly about men. I know that, and but I also want to throw into this. I think the biggest issue we're facing looking forward over the next 5 years with mental health is with young people, and I think we're looking at a real, again, post-COVID, real crisis in mental health in young people, and generally we are going to have to focus resources in a way. Accessing Greater Manchester, I don't know what it's like in the other two parts of the northwest, but access to CAMHS in Greater Manchester is absolutely dreadful, and we really do need to address that.
Thank you very much. Thank you. And thank you for your candour and for your time in answering all the questions today and for talking about your regions. I think Dianne is going to wrap us up and say a final few words. So Dianne, would you like to come back on the screen?
Thank you. I'm not in control of the screen, although my camera is on, so that's working. Thank you so much. A huge thank you to our panellists today for sharing so openly with us, some progress, some successes, and being very open about those challenges that you see. I think it's been so wide-ranging, from physical to cultural issues that are facing you, but really great to hear from you, that vision, that commitment to that moving forward, the shorter term and the longer term, and to really stretching others without thinking about leveraging opportunities. So thank you very much for your time with that. I would just like to point out to those in the audience the opportunity to contribute to an evaluation of the session today. Really important for us to hear your views. You can see the information for that in the chat box. All the materials will be shared with you from this over the coming days, so you can have an opportunity to have another look at those or to share them more widely with colleagues. And just to give a little heads up about the next masterclass, which is Thursday, the 7th of December, that one's going to be on transforming the way we deliver public services using a human learning systems approach. And again, you can find the registration details for that in the chat. Unless anybody from the panel or the wider team has anything else to contribute, I think we're just about on time to wrap up. So I shall leave it there. Wish you all well, and thank you so much for spending your time with us this morning. Thank you. Bye-bye.
Thank you
very much, everyone. Thank you.